are one or two questions on the iPad, but I would encourage the floor to ask the questions and address it to whichever speaker they are meant to be addressed to, please.
While people are getting prepared with their questions, we've got 5 minutes, really. We all have to go somewhere else at 5 o'clock. I'm sure lots of us have to. So there are lots of trainees in the room. So here's a question to Professor Wu. Professor Wu, you obviously, the indications for new devices change with time and experience. So in your opinion, how have the indications for AMDS evolved in the last 2 years? And what's the take-home message for the trainees about the device or that kind of device?
I think AMDS, my indications is gradually changed, learning from the assessment of the distal aorta, closely with it, then the descending, and then the arch with the with angioscope routinely, and now with the TOE combination that and CT scan. If there's no re-entry tear in the arch, no re-entry tear in the descending thoracic aorta, especially with the older patient where you want to avoid the second operation in the proximal descending thoracic aorta or distal arch, these patients I will use AMDS. So that will kind of stimulate, that will kind of encourage the kind of remodeling for the arch and descending thoracic aorta. And the patient, especially with patients with very narrow true lumen, radiological malperfusion, and some clinical malperfusion, sometimes when you see very narrow true lumen, usually means there's no re-entry tear in the descending. That's the reason why true lumen is really compressed by false lumen. In that scenario, by putting the AMDS down, we'll open the true lumen. It goes all the way down to close to the diaphragm. And you can do it from zone 0, you can do it from zone 1, you can do it from zone 2. So that's what I changed the kind of approach and then of the indication. And I'm still trying to avoid using it for any patient with the re-entry tear I can see in the arch branches. Any patient with the re-entry tear in the at least proximal half of the descending thoracic aorta. That's for your AMDS.
Thank you. Any questions from the floor?
Okay.
Shakil?
Thank you, Shakil from Papworth. Excellent presentation by everyone. Just a specific question to Prof. Wu. I think you have highlighted some of the controversies where AMDS should not be used, but the reality is different. It's been used right, left, and center in some places. I've seen in the AATS, it's been put into patients who are 50 years old. Now, if this kind of patient, whilst we believe that it will help in remodeling, but there will be a certain group of patients who will come back for redo. I mean, what strategy do you think of if you have to do a FET in this kind of patient? Because it's the cuff, which is quite narrow, and then you are limited by the side of the stent, and you can't pull it out either. So what's your strategy in future?
Retire.
That's the first important thing. Not many years left. That's a good thing. I think that's one of the issue with the kind of collar area is quite narrow. So making sure that you stretch the collar as much as you can, and so you can still put the fat through that, and then do the deployment. But you will need to definitely extend it with the retrograde TY extension to cover well beyond that, to beyond the kind of the AMDS, beyond the kind of cover completely kind of the overlap with the frozen elephant trunk and the deep branch branches. I think that's the only way to do it. But if you're forced to having to cut it, you may have to cut it, but just be careful. You probably have multiple bricks. Yeah.
I think we've got time for one more question. I think Indu had something for Sabine.
I think Sabine, I think it's too good an opportunity to let go without asking you the question. First of all, congratulations, really impressive series. I'm going to there are a couple of questions, but I'm going to club them into one. In your initial experience, did you still do a thoracotomy and femoral bypass just to be on the safer side? And secondly, is the radial force of this stent adequate? Because there has been talk about the radial force not being adequate. And how have you needed an extra stent to stabilize this in any of these cases? And lastly, how stable is the proximal fixation in the proximal part of the stent?
So thank you for the questions. First of all, we always have a heart-lung machine in backside. We so far never had to use it. The concept of retrograde visceral and antegrade iliac perfusion is quite safe. We have an arterial line on the contralateral leg to check the pulsatility of the flow, to be safe that the retrograde visceral perfusion is right, because you might have a kink on the iliac branch. The machine was never used so far, but you might have a big blood loss during opening up the aorta if you have a dissection, so you have to be prepared that you might have a really good suction and you need some blood for supply during that. We perform coil embolization to avoid that prior to surgery, and the coil embolization has to be done between 3 and 10 days prior to surgery, because otherwise you create new collaterals. What was the next question?
I just say, how stable is the proximal part of the stent with the radial?
It is very stable. So we have a new orientation of the ring stents. So they are orientated in a way that you have no risk of collapse. It's quite stiff. And we just anastomose the collar to prevent backbleed from the intercostals in case of dissection. We never landed in a native aneurysm so far. We usually land in a TVAR. So the most cases had a frozen elephant trunk, and we elongated with a TVAR and landed in the TVAR. And all of the cases were dissection. This is not made for a type 4 repair. Usually we have type 2, and it's a staged repair. And we had no distal migration of the stent graft so far. The case you have seen on the video was the case from Calgary. There we had no matching endovascular stent graft to create a sealing zone, so we had to deploy, this was planned, a stent graft through the access branch to have a proper sealing, but still we have no risk of collapse while we deploy the graft because the ring stent orientation makes it quite stiff. And the radial force is very strong too. This was tested in the experimental setting.
Thank you very much. I think we need to wrap it up. We're getting to 5 o'clock. There are a couple of other satellite meetings at 5 where people may have to go to. So thank you all for an excellent session. And please mark the speakers when you can through the app. If you can please mark the speakers, that'll be very helpful. And I wish you all a good evening and enjoy your dinners wherever they might be, and a few drinks before that, I'm sure.
Thank you all.
Thank you.